to Webinar Wednesday.
Oh,
I'm here in Dental XP to discuss some current knowledge in anterior implant aesthetics. I'm at the university, Columbia University, where I teach about 40% of the time, and 60% of the time I'm in private practice. So I'd like to discuss some of these concepts associated with the most common knowledge associated with anterior implant aesthetics. Specifically, what I'd like to discuss tonight is really talking about the relationship of anterior aesthetics as it relates to immediate fresh socket implants with a provisional restoration, focusing on the single tooth anterior implant restoration. This tends to be a little bit more common now because of the fact that a lot of techniques that we presently have really lend themselves to immediate placement, and we'll discuss a lot of the common issues associated with immediate implants. Specifically, what is the role of the provisional restoration? Because a lot of times we can place a provisional restoration at the time of implant placement, and consequently we can actually streamline procedures for patients. We can eliminate the number of procedures necessary, and therefore we could have greater comfort and greater outcomes for our patients. The role of the provisional restoration is a very new concept, and we'll try to discuss some of these issues as we go through. What really revolves around immediate anterior implants is really two words that really describe the concept, which is really tissue preservation. Several implant companies have actually started to delve into different themes associated with tissue preservation being sort of the priority, or tissue care. So this is a very interesting and new topic that we're really focusing a lot of information on. So over the next 45 minutes to an hour, what I'd like to discuss in relation to immediate anterior implants and provisional restoration is trying to give some of the basic background and understanding associated with this topic. So we'll try to look at some of the current literature and some of the literature of what's reported in regards to survival rates, aesthetic outcomes, and where the future is heading. I'd like to also discuss a concept called dual zone socket management, where I've been working with my partner Dennis Tarnow and Maurice and Henry down in Atlanta with David Garber and some other colleagues down in South America, where we've sort of joined forces to try to look at this concept in more detail and trying to come up with some predictable outcomes as it relates to aesthetics. And then I'd like to come up with some conclusions looking at the background, the research that we've done, and try to tie everything together. So we'll have an opportunity to really look at this subject in depth. Specifically, again, we're going to be speaking about the single tooth anterior restoration. Multiple teeth is a totally different topic, but for a different time. Let's look at the background associated with the subject matter. It's very interesting. A lot of times what happens is actually when an immediate implant is actually placed into a fresh extraction socket, there usually is a gap. Now, what usually derives from the gap are some interesting questions in regards to what should be done with that gap. The most common understanding, or the most common thought, is whether or not to actually place a bone graft into that gap. So the question that really arises is whether or not a bone graft is necessary. Now, when you think about bone grafting around immediate implant in a fresh socket, when you're really talking about bone grafting, there's three main issues that really arise in reference to the subject matter. And those three issues are very distinct from one another, and they would be the following. Does bone grafting around the implant really improve survival rates? Meaning that, is it necessary to actually place a bone graft in order to increase the survival rates around immediate implants, fresh socket implants? The second would be, is it necessary to actually place a bone graft to increase the ability for osseointegration? I think that's something that is always intriguing, that always comes up in discussion. And then the last would be, do we necessarily need to place a bone graft to enhance aesthetics? Now, these three words or these three concepts have very different meanings, and again they're very distinct in what the outcomes are. So if we delve into this concept, we can see more clearly in reference to this what can actually happen. So let's take the first topic, which is really about survival. So the question becomes, if we place an immediate implant into a fresh extraction socket, do we necessarily need to place a bone graft to, number one, enhance the survival rates of immediate implants? Now, if you look at all these authors in the literature to date on anterior implants, there's almost 400 implants that have been reported in the dental literature. On the far right column over here, you can see the survival rates. Now, some doctors have reported 100% survival rate. And 4 out of this group of 8 actually have reported 100% survival rate. And that's very interesting when you really consider immediate implants in the aesthetic zone. So a lot of the authors have reported very, very high survival rates. A very recent paper in PRD in 2011 from Edgar L. Char, who actually I used to teach with at NYU, who still teaches there, actually had a retrospective analysis of about 206 implants. And Edgar's numbers were also extremely high. It wasn't 100%, but it was 98%. He had the largest number. So it's very interesting that when you look at all the survival rates, if you add them all together, the mean survival rates reported in the dental literature is about 97%. Now, 97% is equivalent to delayed survival rates, so these numbers are very, very good. The walkaway message is the following, is that immediate implants don't necessarily compromise the survival rate. They have equivalent survival rates. Now, one of the key elements is obviously, besides proper patient selection and good case selection, would be primary stability. Primary stability seems to be one of the major variables associated with good survival rates. So if you have good case selection of the patient and are able to achieve primary stability, then you should enjoy high numbers in regards to survival rates. Actually, press-fit implants had dropped down to the high 70s or low 80s percentile of survival. And the reason why press-fits have a lower survival rate is really due to primary stability being one of the main factors associated with that. So threaded implants seem to be the way to go when you're talking about immediate implants. Well, when we talk about primary stability, one of the most important factors that first arise when you look at an implant is really the following. When you place the implant at day 0, rarely do you have really any bone healing. It's really, you just have a traumatic injury, the implant's placed in the socket. And what really gives you the ability to actually place a provisional restoration on that implant is really the macro thread design. So if you're really thinking about immediate anterior implants, that the macro thread design is the most critical factor as it regards to initial stability. Because initial stability is really primary osseointegration. You know, osseointegration can really be broken up into 2 factors. One would be primary, and the second would be secondary. Primary stability, or primary osseointegration being initial stability, secondary osseointegration being the microsurface on the implant. So really, when you're talking about osseointegration, primary osseointegration is primary stability. Always look at the macro thread design, and this is Biomet's implant. They have Prevail implant, and they have their certain implants, but they have a very nice aggressive thread design. When you're talking about secondary osseointegration, then look at the microsurface, which would be their osseotyte surface. This happens to be a full osseotyte surface or the FOSS surface. And of course, nowadays, we're always looking at platform switching being a critical design element associated with good implant design. So again, this is one of the features that you would look for in implant. Again, the surface is really secondary to the macro geometry and thread design of the implant, especially when you're considering immediate implants. So we know that survival with immediate anterior implants is very high. It's about 97%, the walk-away message should be that it's at least equivalent to delayed. What was very interesting a few years ago at the Academy of Osseointegration meeting, which is really a conglomerate of very high-level specialists and high-level general practitioners who do implant dentistry, is that a question arose in reference to the subject matter. And it was interesting. About half the audience, of over 1,000 people in the audience, half the audience had no idea about the survival rates associated with immediates. So again, the walk-away message is that they're equivalent to delayed, provided that you have proper case selection and good primary stability. Well, what about osseointegration? That's a totally different question versus survival and aesthetics. And do we necessarily need to have to place a bone graft into the gap in order to achieve osseointegration? We know that Akimoto and Becker talked about a gap distance of about 1.4 millimeters or greater, that if you had a gap distance greater than 1.4 or 1.5 millimeters, that you would have to place a bone graft in order to get osseointegration. But they had laid flaps and pulled the flaps close to the implant surface. In this recent case report, which is a proof of principle report in Ron Nevin's journal in 2011, this is a case report that Dennis Satarno and I had done on a patient. And what the key element here is that when the tooth was extracted, no flaps were raised. It was removed atraumatically. You can see an implant being placed more toward the palate, so there's a fairly large gap distance here. And the key element here was, besides not laying a full flap, was to allow that socket to heal by secondary intention wound healing. You could actually see her after about 6 weeks. The epithelial front hasn't even migrated to the implant surface yet. In fact, epithelium doesn't have a blood supply. Since it doesn't have a blood supply, it's impossible for the epithelium to migrate to the implant surface. The only way for the epithelium to grow is that the underlying tissue has to mature first. So it's actually impossible physiologically and biologically for the epithelium to grow and touch the implant surface first. In fact, the underlying tissue matures and competes for that surface first, and therefore the epithelium cannot migrate apically. So you can obviously see here that there's development of the fibrin clot underneath, and that takes some time to develop. And again, it's not uncommon about the healing process associated with the socket. In fact, whether or not you put a piece of titanium into the socket's going to heal the same way. The fact that you put a piece of titanium here and allow it to heal by secondary intention wound healing is relatively the same. When you see the histology of this implant that's removed, you can see that bone has filled to the first thread. This is actually the facial aspect of the implant surface. And you can clearly see here, bone has filled to the first thread. And if you actually look at that implant at higher magnification, you can clearly see here that bone is contacting the first thread. Now this implant was loaded, and it was a non-platform switched implant that had a polished collar, so you'd expect to see bone filled to the first thread. Again, the key element is secondary intention wound healing, and again, you can clearly see here that the fact that you put a piece of titanium here doesn't compromise or change the biology and physiology of wound healing around and in this socket. Again, epithelium cannot migrate faster than the underlying tissue. Once the underlying tissue has adapted to the implant surface, it's genetically predetermined to form new bone around that implant. You can see here, though, however, if you look at this ridge, this is the ridge at the time of extraction, you can clearly see here that over time that there is collapse of this ridge. Again, if you look at this buccolingual dimension of this ridge with the implant placed at time 0 and after 6 weeks, you can see that this ridge is collapsing. So again, you can have osseointegration, but you may get collapse. Now if you look over here, this is again the implant that is a CBCT of the implant before it was removed. The CBC says that there is bone fill to the top of the implant, and the dimension of the buccal bone plate after healing is roughly 3 millimeters in dimension. Well, the initial gap was a little bit greater than 4 millimeters. So again, on the CBCT, we had about 3 millimeters of buccal plate thickness, as evidenced over here. So that's a net of about 1 millimeter of buccolingual change. So in fact, the buccal plate had resorbed and collapsed by about 1 millimeter. Again, that doesn't mean that you won't have bone on the buccal surface. What that shows is that you can have collapse, provided that the implant is placed more to the palatal side. You should have residual new buccal plate forming on the buccal side. But 1 millimeter buccolingual collapse could sometimes be an issue. Which really brings us to the question of aesthetics, because if we know that immediate implants have very good survival rate, and again, the survival rates can be equivalent to delayed sites, and we know that you don't necessarily need to place a bone graft around the gap in order to achieve osseointegration, provided the implant's placed to the palatal side, and there's no flaps that are raised, and you allow that socket to heal by secondary intention wound healing, we do know that you can get collapse buccolingually, as evidenced by that previous case report, which really again brings us to the point of aesthetics. Now, we know for a fact that there are some issues associated with the buccal plate. In fact, if you place an immediate implant into a fresh extraction socket, that implant does not prevent the buccal plate from remodeling and modeling or collapsing. This is a very well-quoted paper by Maurizio Ruggio down in Brazil. Worked a lot with Jan Lindy at Gothenburg. Now you can see here, this is the preoperative scenario of a lower mandibular canine tooth. You can see how thin the buccal plate is over here. The fact that the implant is actually placed into the extraction socket, you can clearly see here with the red arrow over here, that there's been loss vertically of the buccal plate. Now, the previous case report we showed you, remember we didn't have any loss of the vertical height of the buccal plate. This paper is well quoted, but it's a little bit misleading for the following reason. Note that the implant that they selected is larger than the tooth that was extracted. If you have an implant that's larger than the tooth extracted, Kaneba showed that actually you will lose that buccal plate in height. So this is a little bit misleading, but the general take-home message that implants that are placed into fresh extraction sockets do not prevent the buccal plate from modeling or remodeling is a true statement. However, the clinical example of this dog model is not probably the best example shown in this paper. So that's a little nuance to distinguish those two variables. Well, number two, as we're still on the topic of aesthetics, we know, based again upon a lot of the work that's done in Sweden with Jan Lindy's group, that when they extracted a tooth and they replaced the tooth with an implant, they actually had the opportunity to measure the buccal plate thickness almost on 100 patients. And they found that 90% of the patients that they actually measured this buccal plate thickness, they found that that buccal plate thickness roughly was about 1 millimeter or less. Again, looking at almost 100 patients in the patient pool. So 90% of the patients they had, basically 9 out of 10 patients, had a buccal plate thickness of 1 millimeter or less. And that's a scary number. Again, when you're considering putting immediate implants into fresh extraction sockets. Matter of fact, they found that almost 2/3 of the patients had a buccal plate thickness of 1/2 millimeter or less. So again, 64%, or roughly 2/3 of the patients, had a buccal plate thickness of 1/2 millimeter or less. There's a new paper out by Cook that actually looked at different biotypes. He looked at thin versus thick biotypes. And if we look at the thick biotype numbers, you can see here clearly that what Lindy had reported was correct. That the thick biotype patients had a buccal plate thickness of 1 millimeter or less, and the thin biotype patients had a buccal plate thickness of 1/2 millimeter or less. The bottom line is that whether they have thick or thin, or they're categorized as thick or thin phenotype patients, the bottom line is that they have basically a buccal plate thickness of a millimeter less. What's interesting about the Cook article is that they not only measured 1 millimeter below the crest of bone, they measured 10 millimeters from the crest of bone, and therefore they had a more representative change of what's happening along the whole buccal plate surface. And this was a article looking at CBCT X-rays. So it's very interesting. The good news in the dental literature is that a lot of top-level people are finding the same conclusions, which is very good for validation. The other aspect is the following. Hamli Wang actually looked at extraction skulls, fresh skulls. I actually had an opportunity to email Hamli Wang, and Hamli had said the following. Hamli Wang actually had the ability to look at different measurements on fresh extraction skulls. And he not only concluded that the buccal plate was also thin, he also found that the mean gingival thickness in the anterior maxilla was roughly 0.5 millimeter in thickness. So Hamli Wang had the opportunity to also look at fresh extraction skulls as well as looking at tissue thickness. When Hamli Wang, when he reported this paper, I had an opportunity to actually email Hamli, and I said, Hamli, with these fixated skulls, because when you think about it, if there are fixated skulls, potentially maybe there would be shrinkage of tissue, and he was measuring soft tissue thickness. And he clearly told me that these were not fixated heads, that they were fresh skulls. I don't know where they get them, but he said they were fresh skulls. So, and he's a very good researcher, so he basically found that the tissue was thin. So these numbers of 1 millimeter or less, or 0.5 millimeter or less, or 0.5 millimeter of tissue thickness or less, I mean, these numbers keep on reoccurring. So the bottom line is that, again, there is a lot of potential danger associated with immediate implants in the aesthetic zone because the buccal plate is very thin and so is the tissue. Well, some researchers have also reported on dimensional changes of the extraction socket with the immediate implant and a provisional restoration. Again, these were some of the authors. What the procedure they actually did is that all these authors did not place a bone graft, they just placed the provisional restoration. And they reported again on midfacial recession or vertical changes. And they found the following. Peter Worley, who was really the pioneer looking at this, he actually reported out of the 14 patients that he had in a consecutive case series that 2 patients had 1 millimeter of recession. Joe Kahn at Loma Lumna reported about 0.5 millimeter recession. This author in Italy reported no change, and actually Lyndon Cooper did a very nice prospective comparative study of immediate versus delayed implants, almost an equal number in each group. And he actually found that he had almost 0.5 millimeter of soft tissue gain, meaning that instead of no recession or having some recession, he actually reported a gain. Now, if you've ever heard Lyndon Cooper speak, Lyndon talks about implant positioning being very critical, so I'm not surprised that he actually had a gain because he's probably placing and positioning the implant in the correct spatial relationship. These 2 other authors, Mike Block being one of them, who's used to run LSU's program in oral surgery, actually placed a graft. So Mike Block and Tim DeRourke actually placed grafts with the provisional restoration. And Tim reported no change, and Mike actually reported a gain of 1 millimeter. But distinguishing the fact that the procedure that they actually did was where they were placing a bone graft. The bottom line is that we have different procedures being done with different outcomes by different authors. And so a lot of this information is somewhat mixed together. So it's somewhat hard to decipher, but we do have a range either from, say, a loss of 1 millimeter of recession from Peter Worley first doing this type of procedure to Mike Block actually putting a bone graft in conjunction with the provisional and actually getting a gain. So again, we have to have, or we're trying to have, a little bit more consensus associated with this type of scenario. But let me try to give you an example. This is a particular patient that I had treated, one of my first patients that I had treated using this technique in 2004, so I was a little bit behind in actually doing this type of procedure. It was a patient who actually had a fracture of the root of tooth number 9. He had post and core and a crown on tooth number 9. A friend of mine who actually lives in Japan now, and we also used to get together and play golf. Really nice guy. And again, he had a post and core and crown, and this is actually what happened, that he came in and he had fractured this tooth. This piece of fractured tooth, as seen in this area over here, had not gone beyond the buccal plate. So the buccal plate was completely intact. So this fracture was completely in the dentogingival complex. But not an uncommon scenario where you have a fractured tooth and decision-making processes. Well, do I have enough ferrule effect? Can I actually do maybe forced eruption, remove this fractured piece, do crown lengthening, maybe redo the root canal on a post and core and a crown, versus just atraumatic extraction of the residual root and placing an implant into that site. I mean, these are very, very good clinical scenarios related to immediate replacement with an implant in the aesthetic zone. This patient, again, was treated by myself and Frank Salenza Jr., and you could obviously see here that I've tried to recreate the proper shape and profile to the restoration of tooth number 9. Now, whenever I show this clinical scenario, people go, well, that's really a nice result, and they're happy with it. But let me be very critical about this clinical scenario. Remember, we're talking about different authors and what their outcomes were. You can clearly see here that the vertical aesthetic parameters were managed pretty well. I think that, in fact, compared to this contralateral tooth that has a little recession, we actually have none here, and the free gingival margin of the treated site of this implant is actually more coronal than the contralateral tooth. Now, this implant, again, was just an implant that was placed, and the provisional restoration was placed on top of that, and no bone grafting was performed. Again, an Asian patient with a thin phenotype and a highly scalloped tooth and tissue form, thin tissue, thin gingiva. You can see an implant, again, was placed in this site. Now, I have to really, in full disclosure, really be very critical, like I said I would be. And you can clearly see here, however, we do have tissue discoloration. Now, I'm pointing to the free gingival margin here, but in fact, the patient has tissue discoloration the whole length of the implant body, not just from the free gingival margin, but really the whole length of the implant. And that's a critical fact. Now, I just told you that I was able to manage the free gingival margin very well. But in fact, I haven't really done such a great job because there's certain things that we cannot overcome. And the things that we can't overcome with managing abutment and crown contours that I've managed to do on tooth number 9, you can see here I've tried to flatten out this abutment contour. But look at this buccolingual dimension compared to the natural root on the adjacent teeth. And you can clearly see here that there's been facial collapse. In actuality, we can fool the eye in believing that the free gingival margin is more incisal by playing with abutment and crown contours. But what we cannot fool is the loss of buccolingual volume in this area. So what you would determine that's a good result, talking about vertical free gingival margin changes, like I said, I could have reported that I had a gain on this patient. But in fact, if you had to reflect this flap, you would note that there's no bone on the whole buccal surface of this implant. So that's really the reality. So this buccolingual change, which we talked about before, from what Lindy was talking about, and implants don't necessarily prevent the buccal plate from modeling or remodeling. This is the clinical scenario that you're faced with. So these become really important issues associated with that dirty word called aesthetics. Aesthetics really from a facial palatal contour change or buccolingual collapse. So that's really the discussion. So the background is really talking about not so much survival, because we know that those numbers can be very good. We could talk about osseointegration, but we know you don't have to place a bone graft in around the implant in order to get osseointegration. But the key factor and the big question becomes, do we have to place a bone graft from the standpoint of aesthetics and preventing this collapse of the ridge? So that's really the question at hand. What topics or what literature is presently out there that actually discusses this? And there's some newer concepts that are being presented in dental literature. This is from Marcus Hössler's group in Germany. And they have actually discussed a concept called the socket shield technique, which talks about actually preserving a part of the root in the socket. And preserving a part of the root in the socket is actually acting like a shield, as seen over here, where you could remove delicately basically 2/3 of the root from a buccolingual direction and keeping a third or half of this root in an apical coronal direction, still keeping all the fibers intact and attached to the periodontal ligament on the buccal surface that would protect this buccal plate from collapsing. This was just a case given to me by one of my previous students, Notis Emanuelidis from Greece. He's finishing up his pros training at NYU. And here is an example where he's actually removed that piece of palatal tooth structure, left the buccal tooth as a socket shield, and then placed the implant to the palate. Now, the actual removal of this root takes about 2 hours to accomplish this. So this is not for the faint of heart or the poorly skilled. This is for the highly skilled. One of the issues that can be associated with potential problems would be the following. That when this tooth is sectioned, that during removal or sectioning, that if this root fragment becomes dislodged, that could be that a nidus for a sequestrum, and that could be a big problem. Or during implant placement, if this implant somehow touches this root and potentially could dislodge it, or touches it and can be an area where you can have potential downgrowth of soft tissue, that could be another big problem. So again, Marcus Hössler has reported about this with Notis Emanuelidis and Stefan Fickel. It's a novel concept, but I think there has to be a lot more research and clinical data, as well as histologic data in animals to really validate this. I know they're working on it, but it's an interesting concept. The reason why I'm bringing it up is that you should be aware of present concepts associated with preventing this buccolingual dimensional change. The actual evolution of this concept was really derived actually prior to Bert Langer, but Bert Langer made it very popular in the early 90s, looking at potentially creating more soft tissue in an effort to subsequently bury teeth that were restorative compromised. And back in the early 90s, what we were doing was that we were doing implants as a two-stage procedure, meaning that we would remove the root and place the implant and do primary flap closure over it, so we're burying the implants. What Bert actually described was that if you could decoronate the root down to the bone crest, as seen in the diagram over here, that over time, burying this root and submerging it and decoronating and then root submergence, that the tissue would then fill over this area. And then when he would go back to remove this residual root tip, that he would have the ability to have primary flap closure because he would allow the tissue to migrate over that surface. As seen over here, that you could obviously see that there's tissue that will cover over here. Now, Maurice has made this very popular with Henry and David, talking about not only submerging the root as this technique, but also retaining the root, especially under pontic sites. It's certainly better to have a retained root where the tissue can grow over it, and you could still preserve the ridge under a pontic site versus removing that root where you would get collapse. So again, the initial belief from Bert Langer was using this technique as far as submerging the root and getting tissue to grow over it, and Maurice, Henry, and David talking about not only submerging the root, but also retaining it under pontic sites. So again, if you look at this root and it's been decoronated, that over time you can actually have the tissue close over it. So over a couple weeks' time, you can clearly see here now you can have a closure in this area. Again, Bert was using this as then he could have primary flap closure when he's placing implants, and Maurice, Henry, and David talking about actually using this to help support the ridge underneath the pontic site. So again, Marcus Hössler's concept of this socket shield was really a derivation from Langer, and Team Atlanta. You can see here a little bit more. This lateral incisor with the socket shield after 2 weeks with the provisional restoration looks terrific. Really looks great. But again, this is not an easy procedure to do. And again, we need to have long-term data to figure out what's happening to this root here. The potential for a problem is high. So I would say that this type of technique that's been reported in the literature has a higher risk associated with it versus some other techniques, which we'll talk about. But again, the amount of buccolingual change is seen on this provisional restoration. When I spoke to Notice, he said that on the cases that they were measuring, they had about 0.5 millimeter or less buccolingual change. So again, they're reporting less than 0.5 millimeter, which clinically may not even be relevant from a visual standpoint. Well, what other techniques have been reported in the literature? Again, very new information. Uli Grunder, who actually looked at 24 consecutive cases. He measured at the head of the implant 3 millimeters from the free gingival margin, again where the crest of bone would be, so it's at the head of the implant. And what he did is, out of 24 patients, he had 12 in his control group, where he actually just removed the tooth and did basically nothing. He didn't place a bone graft, and he didn't place a provisional restoration, and he just put a healing abutment there. He wanted to see how much buccolingual collapse occurred at the head of the implant, again 3 millimeters from the free gingival margin. And he found that at the head of the implant, he had about 1 millimeter of collapse. What's interesting in this paper is that Uli Grunder only did a connective tissue graft. Again, no bone grafting or no socket shield technique. All he did was place a connective tissue graft as his test group. So again, out of the 24 patients, the other 12 patients were the test group where he just did a connective tissue graft, no provisional restoration, just a healing abutment. And he found that if he placed a connective tissue graft, he actually had a gain of about 0.5 millimeter. So again, doing something in this situation, putting a connective tissue graft, could actually eliminate the amount of buccolingual collapse or contour change. Again, no histology, just measurements of casts. So these are two of the issues associated with preventing buccolingual contour change. Again, Hertzler with the socket shield technique and Grunder with the connective tissue graft. Which really brings us to the study that we had worked with Team Atlanta and some of our friends down in South America. Again, what we're trying to do is we're trying to look at different techniques to prevent this buccolingual change. Remember I said aesthetics being one of the key elements in regards to potentially placing a bone graft. Hertzler didn't do any of that. Grunder just placed a connective tissue graft. But our question became, well, what happens if you place a bone graft into that extraction socket around the implant? Will it prevent the buccolingual contour change from collapsing? So again, what about dual zone socket management, a concept brought to light by my partner Dennis Tarnow? Now, the dual zone socket management study really revolved around looking at 3 different parameters from a retrospective standpoint. The first thing would be that we're looking at buccolingual contour change, as I had described and what we're really talking about a lot, but we also looked at some different parameters. Another parameter we looked at was peri-implant soft tissue thickness. So we looked actually at the thickness of the soft tissue above the head of the implant. That would be called the peri-implant soft tissue thickness, or David Garber would call it the unsupported soft tissue profile. And of course, the last variable that we actually looked at in the study was gingival tissue discoloration, because we talked about the potential for that in regards to when the implant is placed. Say it's placed a little bit too far to the facial, you have a thin phenotype patient, and you have buccolingual collapse. You could have this potential problem of gingival tissue discoloration that I showed you on my friend Casey. Now, the concept is called dual zone because we actually looked at 2 variables. Again, we're looking at buccolingual collapse. So we're looking at buccolingual collapse from the head of the implant to the free gingival margin. So again, we're looking at this buccolingual dimensional change. Again, above the head of the implant, from the head of the implant to the free gingival margin. So again, dual zone because we're looking at above the head of the implant called the tissue zone. Dennis calls that the tissue zone. And again, below the head of the implant, we're looking at buccolingual contour change. So below the head of the implant, that's called the bone zone. So hence, tissue zone, bone zone, the term dual zone. Because basically, both these variables are changing. And again, for simplicity's sake, let's just talk about contour change, which is really what we're focused on at this point in time. I'll mention a peri-implant soft tissue thickness, just as an aside, but again, the main focus is really looking at contour change. Again, we had the pleasure of working with Team Atlanta, so we had Maurice, David, and Henry, and we had Gino Sardier, one of our partners, working with his sister, Evan, and his brother-in-law, Sergio, down in South America. They're from Argentina. They're a group of oral surgeons as well as prosthodontists, so we had a nice perspective because they gave us some different information, one being using autogenous graft materials. Hanai at the university helping us with statistics, and Adam and I measuring the cast, and Christian Steppert again helping us with the data analysis. Now, Henry has called this into two parts. He calls it the dual zone therapeutic concept of managing these extraction sockets. And again, part one would be contour changes of the ridge. Part two would be peri-implant soft tissue thickness, and part three would be tissue discoloration. Again, it's a retrospective cross-sectional multi-center study on non-platform switched implants. So we're looking back in time. We actually had the ability to look at 7 points of reference. What was interesting is that we had the ability to measure more thoroughly from the free gingival margin all the way to 9 millimeters from the free gingival margin, understanding that the average length of a central incisor is roughly 13 millimeters long. Now, the comparative analysis looking at contralateral teeth has been reported in the literature back in the late 1990s, where Cheng and Wenstrom actually looked at this on delayed sites. So this is not uncommon. This would be the test site as seen over here, tooth number 8. Tooth number 9 was the contralateral control site. And again, we would measure with digital calipers to figure out how much contour change we were seeing. We measured from 0 to 9 millimeters, like I had referred to. The reason why we did that was because we wanted to have a more representative viewpoint of what's happening with the whole ridge. And you can see here on this test site, you can clearly see collapse relative to the contralateral comparative tooth site. From 0 to 3 millimeters, we call that the tissue zone again, meaning that the head of the implant was roughly placed 3 millimeters from the free gingival margin. And from 3 to 9 millimeters, we call that the bone zone. So again, we have this type of data to really look at it more carefully. A lot of the deficiencies with the prior studies was really talking about only 1 point of reference. So if I picked out 1 point over here, would that truly be representative of the whole ridge from a buccolingual dimension? So we wanted to be more scientifically responsible to look at this. Most of the cases of the 54 we had were central incisors. When I first spoke to Maurice, I'd asked him if we can just focus on central incisors, which seemed to be the most relevant teeth. Again, it's very heavily towards central incisors, and again, we had about 54 patients. The key element was that these were non-restorable teeth. We were not treating patients that had active periodontal disease. We did not treat patients who had a history of periodontal disease and a loss of attachment. So we excluded those type of patients, and we also excluded patients that had large periapical lesions at the apex that would potentially have a fenestration of the buccal or palatal plate. So again, we only took and included teeth in the study that were non-restorable teeth, a very specific group, and again, they all had the buccal plate intact. The key element was not laying any flaps, so these teeth were removed atraumatically. No flaps were raised during tooth removal. As I said, they all had type 1 sockets, meaning that the whole buccal plate and palatal plate were completely intact. Again, we looked at different types of abutment scenarios where we put provisional restorations or custom abutments or contoured abutments. And we also had the ability to look at different types of bone grafting materials, bone allografts, autogenous from our friends down in South America, and xenograft materials. So again, we had the ability to look at all these different materials. We had 4 treatment groups, which would be reflective of actually what's happening in a clinical scenario from a day-to-day basis on most practices. The first scenario, or the first group, would be this type of clinical scenario where no graft is placed and no provisional restoration is placed. In fact, a non-restorable tooth could be removed, the implant could then be placed, and just a healing abutment placed with, say, a resin bond retained tooth-supported restoration or an Essex retainer, something that would be tooth-supported. The second group was where the tooth is removed, the implant's placed, and then we could place a provisional restoration. So group 2 was where we placed the provisional restoration. So again, you may have a scenario like this where you place the implant and you have the ability to place a provisional restoration without a bone graft. Again, some people don't believe that's the standard of care, and sometimes when you place the implant, you may not even have a residual gap to actually place a bone graft in. Say, for instance, a maxillary lateral incisor. Group 3 is where you would place the implant. You would then have the ability to place a bone graft in the gap, but you wouldn't have the ability to place a full provisional restoration. Maybe you wouldn't be able to torque the implant to its full torque value, feeling comfortable enough to actually place a fully contoured provisional restoration. However, you would then place a bone graft in this gap, giving the patient a resin bonded retained bridge or an Essex retainer as a provisional restoration. And group 4 is where you're actually placing the bone graft and provisional at the time of implant placement. So you would actually place the implant in, have the ability to place a bone graft and the provisional restoration. This would probably be all the bells and whistles where you'd have the ability to do everything. You'd feel good about the torque value of the implant. You feel that you would place a bone graft in here and then place the provisional. Again, these groups are actually looking at whether or not we place the provisional and place the bone graft. So again, we were looking at some different variables. Grunder just talking about connective tissue grafting, and Hertzler talking about leaving a piece of root structure here on the buccal surface to potentially act as a shield to prevent buccolingual collapse of the ridge. Understanding that buccolingual collapse is probably the most critical. Again, we can play with contours of our restorations, but we can't prevent the buccal plate from collapsing. So our 4 groups would be the following. Doing nothing, where you remove the tooth, just place the implant. Again, no bone grafting, no provisional restoration. Group 2, where you're placing the provisional restoration only. Group 3, where you're only putting the bone graft in, no provisional. And group 4, the bone graft and the provisional restoration. So these are our 4 clinical groups that we had a chance to look at. Again, a retrospective analysis. So what are the results? Let's try to look at the results, and again, we're talking just about buccolingual collapse of the ridge. And let's just look again at the tissue zone, or that part of the zone where we're looking above the head of the implant, from the head of the implant to the free gingival margin. So let's look at this unsupported tissue and what's happening in those 4 clinical case scenarios. Well, these are basically the numbers. Again, it's a comparative analysis looking at the contralateral tooth. So in fact, 0 means that if we had a number of 0, that means that we would have no change compared to the contralateral tooth. In fact, if you looked at all of these numbers, they're all negative numbers, which means that in the tissue zone above the head of the implant, in these different treatment scenarios, that we all had collapse compared to the contralateral tooth. So in fact, no site actually became a 0. They're all negative numbers. Well, if you do nothing, the amount of collapse that you actually have is about 1 millimeter in the tissue zone. Remember, Grunder said he had about 1 millimeter at the head of the implant. So only looking at one reference point. But here we're combining the data from 0 to 3 millimeters, and you have roughly about a millimeter collapse. In fact, if you put a bone graft, or you put a bone graft in provisional, the bone graft seems to do quite well, where you can actually limit the amount of collapse compared to doing nothing by about a half a millimeter. Now, a half a millimeter of gain doesn't seem like a lot, but when we talked about buccal plate thickness and peri-implant soft tissue thickness over the premaxilla, that these numbers of a half a millimeter keep on coming up. That seems to be, the range of the thickness. So a gain of a half a millimeter, or saying that you had a half a millimeter less collapse, that's a pretty big deal. So again, putting a bone graft in, whether or not you put the provisional, seems to, at least in the tissue zone, make a huge difference. And again, that's about a half a millimeter gain, or a half a millimeter of less collapse. That's roughly how you would look at it. Well, what's happening below the head of the implant? Again, what happens below the head of the implant? What is this collapsing in a buccolingual direction? The bone zone data. And you can clearly see here again, 0 being the contralateral tooth. They all have negative numbers, which means they're all collapsing. However, when again you start looking at this group, or these groups where you're placing the bone graft in, now that's a pretty significant difference between putting the bone graft in and doing nothing. Again, this number of a millimeter of collapse seems to be reoccurring. Again, our data being done at a different point in time, looking just at a bone graft versus doing nothing in this group 1. That a millimeter of collapse, again, what Grinder reported, keeps on coming up. Now, if you place a bone graft in, you're really talking about a difference of almost a millimeter, meaning that you either gained a millimeter if you put a bone graft in below the head of the implant, meaning that that ridge is collapsing a millimeter less. And that's a big deal. Again, having a millimeter less collapse, or a gain of a millimeter in buccolingual dimension below the head of the implant and in the bone zone, that's a very big deal. So if you look at the two numbers, you could have a half a millimeter of gain in the tissue zone and almost a millimeter of gain in the bone zone if you place a bone graft. So the bone graft seems to be a very powerful parameter. And again, if you look at these numbers are less than a quarter millimeter buccolingual change. So I think this is a very, very encouraging data without the risk of the socket shield technique, where you're actually trying to hold on to a piece of tooth structure to prevent this buccal plate from collapsing. So again, I think this is very low risk, where all you're doing is placing a bone graft in the gap. I really talked a lot about some of this interesting topic, and it's a really intriguing topic because immediate anterior implants with provisional restoration or aesthetic healing abutment is very, very important. The background we covered, the dual zone study we covered, I think it's very important to understand what we're looking at and what our outcomes were. So really in conclusion, we go back to immediate implants. We have a gap. We may become emotional or not about what to do with the gap. The question becomes, is a bone graft necessary in the gap? Again, from those perspectives. From survival, again, the background we said no. That from a standpoint of immediate implants and survival, that it's not necessary to place a bone graft. Again, we can have equivalent survival rates, 97%, which is equivalent to delayed sites. Second was osseointegration. Is it necessary to place a bone graft in regards to osseointegration? The answer is no. We clearly show that if you don't lay a flap and you allow that socket to heal by secondary intention wound healing, whether or not you put a piece of titanium into that socket doesn't make a difference as far as its ability to heal and form new bone to the first thread of the implant. But when in regards to aesthetics, which is really the question, do we necessarily need to place a bone graft in regards to aesthetics to prevent that buccolingual contour from collapsing? The answer clearly is yes. We have to do that. That will enhance it, especially if we're getting attachment or adherence to that surface of our provisional. If we don't get adherence, the bone graft actually becomes our friend because it acts as an insurance policy. It'll minimize the amount of recession or collapse you'll have if you don't have adherence. So if we look at our 4 treatment groups, again, if you do nothing, you'll lose about a millimeter But again, if you put a bone graft in, you can have about a 1/4 millimeter change or less than a 1/4 millimeter change if you can actually put a provisional restoration on there. And again, if you have adherence, these numbers get very good. In group 4, where you're putting the bone graft in the provisional, you can have essentially no change. And if you just put a provisional restoration only and don't believe in bone grafting or wasn't doing it, the reason why you had good results is because you probably had adherence to that surface and you probably had less than 1/2 millimeter buckling will change. So in effect, the prosthetics becomes very, very important because the prosthetics eventually relates to the aesthetic outcome of tissue preservation, understanding the potential for a prosthetic seal as described by the group in Germany. So that, I think, becomes very important. How do we get predictable adherence? Like I said, the number one thing is cleanliness and having enough vertical soft tissue thickness. The surface texture, again, is the future research. Can we improve the quality that Ron Nevins is talking about, and the material? But like I said, you could have a laser lock surface and you can use the best materials possible to enhance the biology. And what happens is that if you take plaque and you coat that laser lock surface, you coat any of these materials with plaque, you will never get adherence. So again, number one would be cleanliness. And the reason why vertical soft tissue thickness is relevant, because you always have a plaque zone around that abutment. It's inevitable. So you need to have enough soft tissue thickness. The take-home message, if it's there with this minimally invasive protocol, then leave it there. I think that's very important. And the reasons why we all see good results with immediate implants with the provisional restoration is that we can do minimally invasive procedures and we can have the greatest potential for potentially preserving everything that's there. So that's the real key element, and we're understanding some of the nuances associated with it. Well, I've enjoyed the time here being on Dental XP. It's always a pleasure. We have a really great relationship with Team Atlanta. We really enjoy working with them. You can see that the study is a reflection of the thinking associated with their group. I think we think very much alike, and we're always trying to work and strive toward better and better answers. There's still a lot of work that needs to be done, still a lot more research, but having the opportunity to work together is really a pleasure. So I thank you for joining me this night on Webinar Wednesday. Hope to see you in the future on some newer concepts and understanding and ideas. And again, remember, going to Dental XP, the real source in relation to the latest information from the dental experts. So thank you, and again, keep on looking at Dental XP and enjoy all the information that I can lend to you.